Hello, everyone, and happy International Women's Day. Welcome to the March 2021 edition of the Pre-Hospital Care Research Forum Journal Club podcast. As always, the Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. And we believe that it's the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. And here, with the PCRF Journal Club podcast, we take a closer look at some of the latest research happening in EMS. I'm Remley Crow, and today I am joined by Dave Page, Dr. Tony Fernandez, Dr. Bill Toon, and Jeff Rollman. And it is my great pleasure to welcome some of the authors of this paper. We have with us Dr. Josh Brown and Dr. Frank Guyette will be joining us. So thank you for sharing your time. Now, the name of the article that we are going to be reviewing today is the Pre-Hospital Blood Product and Crystalloid Resuscitation in the Severely Injured Patient, a secondary analysis of the Pre-Hospital Air Medical Plasma Trial. And this was published hot off the press in Annals of Surgery. As always, this discussion is going to be paired with an article written by our very own Dr. Tony Fernandez in EMS World called Journal Watch. And we encourage all of our listeners to check this out at emsworld.com under the category of education and training. Thank you all again for joining us. I want to remind you before we kick off that you, the listeners, can use your chat feature on the screen to type in questions and comments as we go. And we will be bringing those into the discussion, so don't be shy. And with that, let's get started. First of all, Dr. Brown, thank you so much for taking the time to join us on this podcast. And for our listeners who may not have had the chance to get to know you yet, would you mind telling us a little bit about who you are and your involvement in EMS and specifically EMS research?
Sure, yeah, so thanks for having me. Really exciting to be here today. I'm Josh Brown. I am currently a trauma surgeon at the University of Pittsburgh. But I think, in my mind, importantly, I spent 8 years as an EMS provider up in Buffalo, New York, and Rochester, New York, before coming to Pittsburgh for my surgical training. And so, that was probably my biggest regret of having to leave EMS to do surgical training. And so I have continued to study that with my lab and do really exclusively research now looking at pre-hospital trauma care, pre-hospital resuscitation, and sort of EMS system design. And so this is an exciting thing to be able to talk to you guys.
And we're really excited to be able to talk to you, especially knowing that you're a fellow statistics nerd. Promise not to go too deep into the statistics, but definitely something we love to talk about. And so, you know what, let's dive right in. The objective of this particular study was to determine whether pre-hospital blood products reduce 30-day mortality compared to traditional crystalloid-only resuscitation, specifically for patients at risk of hemorrhagic shock. And so I'm curious to hear a little bit about the background of what made you all decide to study this particular research question.
Yeah, so it was interesting, and I guess backing up to the original PAMPer trial, which was funded by the Department of Defense, that it was really interested in looking at plasma resuscitation in particular. The military has been really innovative in looking at blood product resuscitation in the far forward field and showed some good results. And so actually Frank and I had looked at that in some of our data and some other studies. And when the military came to the plasma question, the PAMPer trial showed one of the largest reductions in mortality ever published for a pre-hospital intervention in trauma, almost 10% absolute reduction. And so as we looked at the rich data that we had from that trial, we kind of realized that we had this really sort of nested, interesting experiment in that, in addition to the plasma that was part of the trial intervention, almost half of the air medical bases that we used were carrying PAC cells already as their standard of care, and the other half were just using crystalloid. And so we saw the opportunity to really look at whether there was some synergistic or combined effect of using both, as whole blood has really come onto the scene in trauma, and we're using a lot of whole blood in hospital to resuscitate our injured patients.
Very cool. And it's nice when a natural experiment occurs within a larger trial. And I'm glad that you mentioned the PAMPer trial. This was the parent study that this sub-analysis came out of. Could you tell us a little bit about the systems that were enrolled in this trial? Like how many there were? Were they all helicopter based, or what do you know about the systems who were in the parent trial?
Yeah, so we ended up including 9 trauma centers, really over 6 sites, with a couple of trauma centers, enrolling at each of the sites, and that gave us ultimately 27 air medical bases. It was a little bit of heterogeneity among the agencies that were participating. They were all air medical agencies. As it's, as you guys know, it's a pretty small minority of ground agencies that are able to provide blood product resuscitation in the field. But it ranged from our stat medevac program in Pennsylvania with 18 bases, a pretty large network, to some of the centers had a single hospital-based air medical crew. And so, we did get a nice heterogeneity of services that I think contributes to some of the generalizability of the findings we had.
It's always important to get a representative group. And you mentioned that some of them were already carrying PRBCs. So there were different types of blood products that were looked at. And I think it would be helpful, just background for the audience on what were the different types of blood products and how is this different from, sometimes we've been hearing the words whole blood, we've heard plasma, PRBC. Could you just give us an overview of what those were?
Yeah, so PRBCs, or packed red blood cells, is what some of the agencies were carrying already as standard of care, and that's when you fractionate the blood into the red blood cells that primarily have the oxygen carrying capacity, and so that there's a number of agencies that are already carrying this in terms of aeromedical transport, and offer that as part of their repertoire for treatment of patients in shock, not just trauma, but anyone that we see with GI bleeds and things like that who are losing blood. We have the ability to transfuse them on the way to the hospital. Now, the PAMPer trial was using what we call fresh frozen plasma. And so, again, when you fractionate the blood, it's sort of the liquid component that contains a lot of the clotting proteins. And so, the two kind of main reasons that the military was interested in plasma specifically were that, one, we know that people, when they're bleeding significantly in hemorrhagic shock, they develop what we call this trauma-induced coagulopathy, where the more they bleed, they lose the proteins that help initiate coagulation. And so they continue to ooze and bleed from the injuries and raw surfaces, and that can really get people into trouble. And so plasma replaces those proteins, and really conceptually was the reason that people started to get really interested in plasma. I think it turns out there's probably a number of other effects related to keeping kind of the lining of the blood vessels intact, and so the fluid and blood don't kind of leak out, and some of the immune effects that plasma has. And so that gets frozen, and then you can thaw that and provide that to patients. And then whole blood is something that we're starting to use now in the hospital, and we're actually just finished up a pilot trial where we have whole blood on our helicopters. And essentially that's, instead of fractionating the blood and separating it into the red blood cells and the plasma and the platelets, you just take the whole unit that was donated, and you give that right back to the patient. Because interestingly, the military's been using whole blood for a long time, because when somebody casualties show up, they have a walking blood bank, and other combatants will line up and they'll take fresh whole blood from soldiers and transfuse it right into the injured combatants. And we started to fractionate blood on the civilian side, and then probably 10 years ago, sort of the hot topic in trauma surgery was recreating whole blood by giving people red blood cells, plasma, platelets in a 1-to-1 ratio. Because if you're losing whole blood, you need to replace all the components. And we found that that was pretty important. And so now we're starting to think, well, if that works in the hospital, why not push this out into the field?
Right, and I think that's a very important question and helpful background to understand that the different components of blood products are available as well as whole blood itself. And I know that we're going to get into some of the logistics around carrying these different types of products. But before we dive into the results and some of these logistics, I do want to turn it over to Dr. Tony Fernandez, who is going to talk just a little bit about some of the methods involved in this study and some of the analysis conducted. So, Dr. Fernandez, take it away.
Well, good afternoon, and thank you, Dr. Brown, for joining us today. I really appreciate your time. And this is a great study. I'm looking forward to reviewing it. So my first question, when we were reading this study, it looked like there were about half of the included the pre-hospital packed red blood cells as standard of care, while the other half had something along the lines of crystalloid only. Can you tell us a little bit about how this impacted the training of the EMS providers in the field and some of the logistics of how that was delivered?
Yeah, so each of the site PIs had to go out and do a fair amount of training, and it actually really played into when we were starting to select the sites. Because as you know, there's sort of different compositions of crew, and we had to make sure that at sites that hadn't been using blood products in the past, that sort of their protocols would allow them to deliver those blood products, even if it hadn't been something that they had done in the past. And so we definitely spent extra time at the sites, training them to deliver the plasma transfusion and really all the regulatory things that go along with that in terms of making sure that it's stored properly, regularly checking the temperatures to make sure that it's not getting too warm and that you would have to end up wasting the product, and then really a lot of documentation so that we could track who got what specific units, because another big part of this and the thing that we always want to guard against is any transfusion reactions, and being able to track that. And so that was a new process for some of the systems that hadn't been doing the blood product transfusions already.
Absolutely, thanks for that. And part of your study, you said that this configuration, it led to 4 groups for the analysis. Can you give us a little bit of information about how the treatment groups were delineated?
Yeah, and so what we wanted to look at, right, is, we kind of started off and we're thinking, well, is there some benefit to patients getting both? And so we were, looking at then the systems that were able to give blood already and, we're using the plasma intervention. And so because of the way the trial was set up, plasma was going to be the first intervention if the patient met inclusion criteria if they were on a treatment month. And so they would get plasma first, and then if they were still hypotensive or met other sort of shock criteria, then they would deliver the pack cells. And so we were able to identify that group that had gotten both, and then we were able to, in the bases that didn't offer pack cells, take the treatment arm and delineate patients that just got plasma as part of the treatment intervention. And then, similarly in sort of, the control arm of the trial, that split into patients, who didn't have the availability of pack cells, and so they only got crystalloid, and we're able to, record that. And then finally, patients who didn't have plasma because they were on a control month for that base. And so then when those patients met inclusion criteria and had evidence of shock, they would deliver their pack cells to those patients as part of their normal protocol.
That's great. And can you tell us a little bit about, since we got to, you did mention the inclusion criteria, can you talk a little bit about how you identify patients for inclusion and what criteria you use for exclusion in your study?
Yeah, and so for the original trial, the main inclusion criteria is that the patient had to be what we sort of term severely hypotensive or a systolic blood pressure less than 70, and that could be at any point during care. And so the original trial included both patients treated at the scene as well as transfers from other hospitals. Although for this paper that we're looking at today, we excluded the patients who were transferred just because we didn't have as much data on what blood product and crystalloid they might have gotten before the air medical crew arrived. And then if they didn't have a blood pressure less than 70 systolic, then if they had a blood pressure between 70 and 90 and were still hypertensive and were also tachycardic with a heart rate above 108. And we sort of had taken our cue from the ROC consortium with some of those inclusion criteria. And then our exclusion criteria for the trial were mainly trying to sort out people with isolated traumatic brain injury, ground level falls, extremes of age, and certainly because this is a randomized interventional trial through the vulnerable populations of prisoners and pregnant patients, when we knew that at the time.
Absolutely, makes great sense there, and that was, I think, well thought out. Now moving on, I know we talked a little bit earlier before we started the call about how the three of us who we can see right now are pretty much statistics geeks. So we're going to geek out for a quick second on some stats. Our audience, there's a lot of folks in our audience who are budding researchers, brand new researchers, or would just like to get into research. So I don't want to get too far into the weeds on this, but I would like to just talk a little bit about how you handled missing data. You noted that there were about 6%, missing data was very low in your study, with just about 6% with missing for 30-day mortality, 2% for injury severity score, and about 2% for abbreviated injury scores for the other abbreviated injury scores, excuse me. And you did some multiple imputation here. Can you just tell us a little bit about the process you use for multiple imputation? And again, we'll geek out some more later, but just keep it as simple as possible for some of the folks in our audience.
Yeah, sure. And so, it was a little bit of a treat to have that little missing data, because I'm used to using EMS charts and trauma registry data where I'm usually looking at 20 to 30% of pre-hospital vital signs and things missing. So certainly doing a trial and really intentionally capturing this data helped. But as part of the original trial, we also looked at imputing the data, and that was part of our planned protocol in the event that we were missing more data than we'd hoped. And this process of multiple imputation, I use pretty commonly for most of my studies, and the idea really is that you can use regression modeling to say if the patient's missing the heart rate for the pre-hospital period. You can build a model with predictors that you think would do a reasonable job of predicting what that heart rate might be for that patient based on the information it takes from other patients where the heart rate might not be missing. And then what you do is you do that several times, and we did 20 imputations for this. So that what you eventually get is a distribution of what might be an educated guess at that missing heart rate for that particular patient based on what their blood pressure was and their heart rate when they got to the hospital and factors like that. And so it builds, you essentially inflate the data set where you then have, they might have given a heart rate of 68 and one of the imputations and 72 in the next imputation and so forth. And you can use then more advanced statistical techniques when you analyze the data that sort of uses a distribution of imputed heart rates and accounts for sort of variability between those data sets. And I think that's important. Some of the things that we often hear from less statistics savvy reviewers isn't that just making up data? But I think this is a very well validated way of doing this, and certainly I think geeking out a little bit, people have done some simulation studies and things like that that show that this actually gets you a very good approximation for certain types of data if you have good predictors of what that missing data might have been. But I think importantly too, then you don't have to throw those patients out. Because what happens is when you're trying to analyze the data and they're missing a key piece of data that you are including in your model or in the analysis, that patient can't be included and gets thrown out of the analysis. And so you can really systematically bias your studies if you don't address missing data, and it tends to be missing it in a way that impacts the results.
Absolutely, that was a great review. Thank you. That was right on par with what I was looking for. And I think that, just to reiterate, this is well validated. Multiple imputation, multiple studies have shown it. And just you took it a step further, which I thought was really neat, that you also did a complete case analysis and you found that your results were really similar. And I think that going above and beyond. So I commend you for that.
Yeah, I think I think it's always important because it kind of gives you confidence. So if you get the same answer, the results may be slightly different, by decimals, but if you get the same answer, you can be pretty confident that there's not something kind of strange going on with the data. And then I always worry if we're imputing and getting very different results, then we worry that the data is missing in a systematically biased way, and we might have to look at different ways to analyze that.
That was great. And moving right along, so after you imputed your data, you ran your regression models, and first you evaluated the association between 30-day mortality among your treatment groups, and you were able to adjust for a lot of variables: age, mechanism of injury, pre-hospital time. I believe it was that pre-hospital scene time.
Is the total pre-hospital time, sort of time from enrollment. So actually when they arrive at the scene, so it's scene plus transport time to the hospital. And
the pre-hospital crystalloid volume, you were able to adjust for multiple variables, and that was really cool. But given that this current study was a secondary analysis, I always like to ask the investigators, if you could go back, were there additional variables that you would have liked to have collected, given what you saw in your results?
Yeah, I think the key thing that we would have wanted to get actually is I mentioned before, we excluded transfers because we didn't really have reliable data on how much blood and or crystalloid they had gotten at an outside hospital. And so certainly that cuts down, our power and our numbers. And so if we were able to kind of, design it specifically for this research question, I think it would have been important to go back and be able to capture that data in terms of transfusion and crystalloid at an outside hospital, and be able to include those transfer patients as well.
That makes perfect sense. And finally, can you tell us a little bit about how in a secondary analysis, you evaluated the impact of dose? And can you tell us a little bit about how you ran that analysis?
Yeah, and so for our primary analysis, we used sort of just a binary indicator, yes, no. They got pre-hospital packed blood cells and or the plasma, and just then we were able to create those 4 groups, and it was a sort of yes, no indicator which group they were in. Whereas for the dosing strategy, what we took the patients who got either packed cells or plasma, and then use the actual volume of transfusion that they got. And so, most agencies were carrying up to 2 units of packed cells, if that was part of their standard of care, and then as the trial intervention was up to 2 units of plasma as well. And so some patients could actually get 4 units of blood product during their pre-hospital phase of care.
So interesting, and I know that all of our audience is chomping at the bit to hear the results. But before we run there, I'd like to open it up to you, sir, and if you could tell us if there's anything else about the methods that we haven't discussed that you'd like to let our audience understand, and also open it up to any of our panelists who have additional methods-related questions.
I guess the kind of 2 key points here is, one, because this was a secondary analysis, you brought up the things we controlled for it. In the original trial, the whole point of randomizing people is to, that any imbalances would be, due to random chance. And so we, typically in the PAMPer trial, we didn't control for anything because in theory, and when you looked at our sort of demographics, the groups were all matched. But because we kind of took this outside the context of the randomization scheme, we had to go back and then be able to try to control for confounders since the groups were no longer randomized. The other important point that that I think is key in a lot of the research that I do is accounting for clustering of patients, which we did, because if you kind of think it makes sense that patients who are treated either by the same agency or base and then go to the same trauma center are going to get, there are going to be sort of differences in their protocols and the way care is delivered. And so those patients will tend to have more similar outcomes with patients going to the same center or treated by the same EMS agency than a patient who was treated at a different place. And so we always pay attention to try to adjust and account for that clustering effect. And that even within the original trial was an important thing for us to do in terms of the statistics.
Thank you for that. That was a great addition. If we don't have anything from the panelists, I won't hold us back anymore. Let's see what you found. And thank you very much for running through that with me.
All right. That was an exciting look at some actually really robust and exciting methods. So thank you. Anytime we get to talk about like time to event and survival analysis is always a good day in my book. But let's go ahead and move into the results, and I will invite panelists to pop their cameras on if they have questions, and same from the audience, feel free to chat your questions as we go and we'll try to get those answered. So diving right in, there were 407 patients included in this study, and table 2 is going to show our baseline characteristics of each group. And so I wonder if you could walk our audience through why it's important to look at the characteristics between groups, and was there anything that stuck out to you that we should bear in mind as we interpret these results, or did you see similarities overall?
So I think overall we saw a lot of similarities, and and by the nature of generally taking this from a randomized trial, that reduces the likelihood there's going to be big differences. But it is important, and as I kind of mentioned towards the end, that we took this out of the context of the randomization scheme. We wanted to make sure that there weren't characteristics of one group compared to others that might actually be more responsible or really explain why we found the results that we did without us kind of being able to adjust for that or know that that was a potential confounder. I think the biggest one that we saw was the difference in pre-hospital crystalloid across the group, because remember that even though we had one group that only got crystalloid, the other groups, even though they got maybe 2 units of PAC cells, if they still were hypotensive, they were giving them additional fluid. And what we also saw, we were able to capture, when an air medical crew, rendezvous to pick up a patient from a ground crew, that ground crew may have given some fluid, especially to somebody who was in shock. And so, those patients that were getting blood products ultimately in the field tended to get a little bit more pre-hospital crystalloid overall, and so we thought it was important to identify that and adjust for that in our modeling approach.
Yeah, that's an excellent point. And here, of course, we see some p-values less than 0.001, but I like to look at this from a practical approach. Are these really that different that we need to bear anything in mind? And in this case, I'm not seeing anything that jumps out at me that, well, these groups were so different that we should really keep it in mind as we continue into the results. So excellent way to look at the different groups and compare. All right, now the moment we've been waiting for. I feel like I should do a drum roll or something. Getting on to figure 2. They do say that a picture is worth 1,000 words. So let's take a look at these curves. Now, these are the results from the survival analysis or the Cox proportional hazards regression. And you know what? This is your study. I will let you walk us through. What is it we're looking at here?
Right, so this is a pretty standard survival curve, although remember there's a couple of ways you can look at this. One is what they call Kaplan-Meier, where it's unadjusted and it's just the overall survival of the groups. And so we did that in the original trial because we weren't adjusting for anything. So these are adjusted curves from the regression modeling, and so this is accounting for all those confounders. But what you are looking at is the proportion of survival or adjusted survival, and so you want to be on top of this curve because it means that you had the highest survival rate. And what you see is that the group that was getting both PAC cells and plasma did have the highest survival of the 4 resuscitation groups. And that was followed by patients that got just plasma and then just PAC cells, and then the lowest survival of all the patients were those that were getting only crystalloid.
Excellent. And we have Dr. Guyette has just joined us. Welcome aboard. And thank you for
my apologies, late to the party, but I'm sure Josh was holding down the fort, no problem.
Absolutely, and fashionably late with the mask. I love it. So we were just taking a look at the main results here, but let's take a break and have you introduce yourself for the audience, if you will. I'm sure they would love to hear about who you are, what you do, and how you got into EMS research.
Sure, my name is Frank Guyette. I'm an emergency physician and EMS physician at the University of Pittsburgh. I started out as an EMT in New Jersey when I was in high school, and kind of worked my way through and pursued science both in molecular biology and public health prior to going to medical school. And that's kind of what got me situated in pre-hospital research. And the other thing that was a real driving factor is the fact that so little of what we do is evidence-based, that we extrapolate all these things from the hospital. And I've had the great fortune of working with lots of incredible partners at Pitt, like Christian Martingill and Jason Sperry, and Josh, who is a fellow former EMS provider and a real kindred spirit, where we are trying to help move some evidence-based research from the hospital to the aircraft and to the ambulance.
Well, thank you. It is so great to have more fellow research nerds here. And I love what you said. We talk about this a lot on the podcast, that setting really matters. We've talked about the parachute study where, randomized controlled trial of parachutes, turns out parachutes don't save lives. Well, if your setting is the airplane is on the ground, that is true. So I love that we have dedicated researchers like the both of you looking specifically at the pre-hospital setting and do these things work. So speaking of do things work, we were just talking about the main result of this study, taking a look at the Cox proportional hazards models and seeing that there actually was a difference observed. And I'm curious, is this the order of blood products ranking that you all would have expected? Did you expect that one would perform better than the other, or that a combination would perform better?
I think our sort of alternative hypothesis was that the combo would be the best approach, and again, taking some of the evidence that we have from in-hospital, our what we call damage control resuscitation, where we try to replace whole blood, with the components we have available, and so we thought that would probably be what we found. And then, it kind of filtered out, the plasma trial that had done so well in PAMPer, kind of came out as the second winner. But, you can kind of see that really the combo is far ahead, and plasma and PAC cells are kind of close together. And probably, there's sort of overlap in the effect sizes, and crystalloid kind of came out on the bottom. So I don't think we were too surprised, and it kind of follows our hypothesis and kind of what we know about what we're doing in the hospital.
Hi, it's Dave.
To that point.
Oh, go ahead, Dr. Gay.
Oh, no, sorry, Dave. I was just going to say, to that point, we have been generating some preliminary data based on whole blood, and it's substantiating these findings. And Josh and I had this same conversation when we first saw this data, probably a year ago or so. And the first thing that it brought to mind was, there's this potential deleterious effect of crystalloid, and what is the right amount of crystalloid, and can we define what the right amount of crystalloid was? And our hypothesis from that is that there probably is kind of a U-shaped curve, right? Too little, and you have hypoperfusion and end organ damage. too much and you perhaps cause endothelial injury or dilutional injury. So, can we define what the right amount is? And, ideally, we would just give whole blood to everybody, but that's not yet available. So sorry, Dave, I didn't mean to cut you off.
No. I find this fascinating, and I've been hearing about whole blood a lot. Dr. Wampler in San Antonio has been a big advocate of whole blood, and so we've been, cautiously looking at this, thinking, well, can we actually carry this in an ambulance? And I want, if you could, for you to put it in context for us about some of the studies that we do in trauma are done on the battlefield, and these are young, healthy, for the most part, males that are in a certain age bracket. And so part of the question here is does this involve patients that are not necessarily in that kind of stereotypical battlefield condition? And also the criticism or question that will come about how much of this could really make a difference in urban EMS systems or even suburban EMS systems where you're, 15 minutes away. I'm old school. I was taught 2 14 gauge IVs, dump all the fluid in that you can, and then, have been kind of relearning all of that, and wondered if this, because particularly this figure takes us to 48 hours. And so I'm wondering if those first hours are a bit like other things like STEMI or getting to a trauma center, where those early decisions actually have incredible downstream effects. And can you put that into context for us?
Dave, that's a great question, and unfortunately the answer is it depends. Clearly there's a much stronger effect size, and again, these are all subgroup analyses, so these are associations, not causality. But there's a much stronger effect size for patients with TBI. There's a much stronger effect size for patients with blunt trauma. So when you get back to that, your question about what if I'm in an urban area? Well, if it's urban and it's penetrating trauma to the thorax, then we know pretty definitively that the most important intervention is diesel, right? But if you have a blunt trauma out in the community, even in a suburban setting, then this is probably the right answer. The other point that you brought up is what about the patient population? And Remley, you said location matters or context matters, and this is the other part of it is this study was not 18-year-old recruits who are all in the peak of fitness and have no comorbid illness. The average age, Josh, was what, 46 or so, somewhere in that neighborhood. And with all the standard comorbidities of people eating Western diets, much, and I think that part of this is generalizable, right? If you are 2 blocks from the trauma center and you have somebody with a GSW to the chest, then you should throw them back in the truck and go as quick as possible. But if you're 15 miles out of town and the patient's a blunt trauma victim, then this is probably the right answer.
Yeah, I think this study and the sort of series of study we've been working on related to PAMPer database and pre-hospital resuscitation has actually really started to change my thinking about this. And I think, we always talk about pre-hospital time and things, and I think what some of this data really is starting to point to is that there is a time to critical intervention. And if that critical intervention is me opening your chest up to sew a hole closing your aorta, then you need to get to the trauma center. But if you have broken femur and your spleen has got a laceration and you have a retroperitoneal heel and you're losing blood in multiple places, and you're going to be 20 to 30 minutes out from the trauma center, then the critical intervention is getting blood product resuscitation as early as possible.
I can't emphasize enough how important this part of the conversation is, the complex thinking of not just saying, oh, blood is either good or bad. Blood is probably good for certain subsets or any intervention. And we've seen this in studies related to TXA and a lot of different interventions in the pre-hospital setting where we're looking for this nice, clean binary answer of, yeah, it works all the time or it doesn't, but rarely is something that simple. So I love the layers of complexity and that you've sliced the data in ways that we can look at that. So we can start to look at, oh, for blunt trauma, these are the results versus something like a gunshot wound is going to have really different results. So thank you for that part of the conversation. And I see we've got Dr. Toon has just joined us. Do you have a question?
Yes, I have actually two questions, and I don't know if it's something I missed or anything like that. So do you feel any of the patients that received a blood product, should they not have received a blood product?
That's a good question too, and I think that we were very concerned initially that we would see a lot of transfusion reactions, that we would see things like trolley and taco, and I apologize, sorry. So transfusion-associated cardiac overload, transfusion-associated lung injury, which are, you know, the folks in transfusion medicine are very much aware of what the potentially negative effects of their intervention are, and they're very astute and very vigilant about screening people for those things. And you know, we're kind of the cowboys, kind of giving it to everyone who meets, you know, these very, very simplistic physiologic criteria. And the answer is that we actually don't see a lot of side effects. I think we had 1 or 2 transfusion reactions in the entire study. We are judicious about the way we administer blood products, and in the long run, you know, giving these blood products early may reduce the total number of blood products that the patients receive, and we've shown that in some of the sub studies as well. And that has the advantage of decreasing the risk of immunologic reactions, you know, resulting in volume overload or in lung injury. The flip side of that, though, is that you know, these are still relatively small studies. We're talking a few hundred patients, and as we move out to larger and larger utilization of blood products, we may see real complications. So I think we have to continue to be vigilant and look for those subsets of people that maybe we shouldn't give it to. But thus far, I think we've been pretty lucky. Josh, would you agree?
Yeah, I think, you know, and again, so we haven't really touched too much on this, but you know, this was done under exception from informed consent. And you know, one of the criteria is that we really have to have good evidence and faith that the potential benefit really outweighs the potential risk. And so that was important in us selecting the population that we're going to give it to. So, you know, really focusing on a shock population, and the overall trial had about a 33% mortality. And so this was a sick population that I think, you know, we felt would benefit from these interventions.
Thank you. That answers. Matter of fact, you answered several questions. Other questions I had written down here throughout the whole thing, and sort of says, darn, I can't even ask those questions or anything. So I didn't pick it up, but what's the crew configuration? Was it consistent? You know, was it paramedic, nurse, physician, or was it pretty consistent across your spectrum? And I'll let someone else ask after this.
Sure, we fly about 90% nurse paramedic. And there are occasions where a physician or an APP will replace the nurse, but that is an infrequent exception rather than the rule.
Excellent point. All right, and I see we've got Jeff Rollman. Do you have a question you'd like to ask?
Yes, thank you. First of all, thank you so much, Dr. Brown and Dr. Guyette, for joining us. Definitely a huge honor to have you share your excellent work. I have 2 questions for you both. First of all, I was wondering about time, pre-hospital time, and the impact of time. Is this intervention, I mean, of course, any EMS intervention potentially could lengthen our scene time or delay our arrival at the ultimate destination and in the OR for these trauma patients. Did you see any effects of plasma administration extending pre-hospital time? And then I guess a linked question with time. I mean, we're looking at relatively short periods, but did you track if the plasma was administered maybe in the first couple of minutes on scene, or maybe later in transport after some crystalloids were already transfused, and if kind of that temporal element may have affected the results at all?
Yeah, I was just going to say, maybe I can answer your second question first, which is because this was a pragmatic trial, we did not dictate how people transfuse the blood product, and there was practice variation. Even though most of these agencies, half of them had carried blood prior to the trial, where they administered it varied. In most cases, they administered it in the aircraft, which has the distinct advantage of not really delaying the scene time, but is detrimental in the sense that it takes longer to get the blood to the patient. And then a minority of them brought the blood directly to the victim at point of injury. I don't think we've looked at that. We've tried to separate that out in subgroup analysis.
Yeah, and kind of overall looking at that our scene in total times were somewhere 30 to 40 minutes was the general time we're looking at. So it's a little bit longer, and I think one of the interesting things that also came out of this is, so in addition to the PAMPer trial, there was also the combat study that was done in Denver in an urban ground system where they were administering plasma. And when we had combined these groups as part of a harmonization study, the DoD kind of wanted to look at some different settings. The interesting thing related to time that came out of that was, when you looked at patients that had times under 20 minutes, plasma really didn't matter. But when you looked at over 20 minutes, that's really where there was a significant survival benefit. And so again, for me, that brings it back to this idea of, there's a time to critical intervention. If you're going to get to the trauma center, before you're going to get 2 units of plasma in, then it's probably better to get them there and have the plasma at the trauma center. And if it's not going to be quite as quick, then getting this blood product transfusion early on seems to make a difference.
Thank you. Thanks for sharing that. And second question too, I think we had briefly mentioned before about TXA, and TXA is a drug we have talked about on our podcasts in the past, and it's something that is slowly growing in use, not just in air medical, but many ground EMS services use TXA. So I was wondering, was TXA being used by many of these services in your trial? And is it something that you think could be a kind of a synergistic strategy of using TXA and blood products?
Well, we're not giving TXA as part of this trial because we're doing the STAMP trial after this, and so we didn't co-enroll, so these agencies weren't using TXA. And so, we, as part of the STAMP trial, have found that there, again, kind of going back to this idea that there's complexity and layers to this. It wasn't everybody that benefited, but it was certain subgroups in severe shock and got higher doses and early on. And so, just like this, we're now working on some secondary analysis of STAMP, and we just submitted an abstract that looks like there may be some signal of combining packed red blood cells and TXA in the sickest patients in severe shock. And so stay tuned, because you'll be seeing those results out in the EMS literature.
Yeah, and Jeffrey, I think that's a really good question, and I think it's a really important one, because who should we be giving TXA to? And to Remley's point, that is such a complex question. And the effect size is small. Even in CRASH 2, we're talking a few percentage points, and that's still important, because that could still be thousands of lives saved over the course of trauma patients, particularly if the negative effects or the cost, both societal and economic, of administering TXA are low, which we believe them to be, and I think we have really good robust evidence to say that both the risks and societal costs are low. So we should be pretty liberal about using TXA. But TXA is only going to benefit a minority of people. But to Josh's point, the people that benefit from TXA are the people in shock, who are the same people we're giving blood to. So we should certainly explore that, and I think that's a gap in the evidence that we really need to kind of tackle as one of our next big efforts.
That's a fantastic analysis that I look forward to. I see we've got Dr. Toone back.
So I'm a service director who works closely with my medical director. As we read through this, what does it take towards our practice? And I'd like your thought of air versus ground.
Maybe
in terms of
should we implement such a program or not?
Yeah, so I think that air and ground are really surrogates for a couple of things, right? So they're surrogates for distance and time. So typically your air services are going to be farther out and are going to be have longer times to get the patient to definitive care. They are also surrogates for population. So typically urban populations are younger and have higher incidence of penetrating trauma. And they're also surrogates for skill. So I don't think that the mode of transport really matters. And I say this as a guy who has spent his whole career in air medicine. I think what really matters are we treating the right population with the right provider? So I think if you have a ground service that has appropriately trained people and you have long transport times to definitive care, then blood might be very appropriate. And trying to come up with a plan to administer blood in the field using those providers, and maybe not every provider, but maybe a supervisor or a special tactical group or something of that nature, is the right answer. So it's going to be very system dependent. But if you have a high proportion of blunt trauma, if you have a high proportion of patients who have prolonged times to definitive care, then you should probably carry blood.
Yeah, I think, like we mentioned, this is the biggest survival benefit that's ever been published for a pre-hospital trauma intervention. So that's pretty remarkable, although acknowledging that, there are a number of logistic challenges to implementing a program like this, and frankly, upfront costs and ongoing costs as part of this. And our hope too is that down the road, technology and transfusion medicine advances to the point that makes this accessible widely. And things that we look to on the horizon that I think are really exciting are things like freeze-dried plasma. All right, that you can throw a bottle of it in the back of your personal vehicle and reconstitute that and be able to give somebody plasma on the scene. I think would be potentially a really big game changer for pre-hospital resuscitation.
Yeah, and a shout out to people who are being really.
Data. I like the fact that you brought up the importance of having data and understanding your system to really make the decision whether to move forward or not, because I think sometimes emotions move things when not having the good facts and the data. And I think that we are, having been in this for as long as I've been, as I know we have a tendency to go by our gut where there's a lack of support for really what's going on, and that can create complications and doom a program before it really has a good chance to have a positive impact. Thank you.
Yeah, and I was just going to add to that there are people out there doing really creative things, and shout out to the folks in San Antonio who have worked incredibly closely with their blood banking folks, who have found ways to get over supply issues by their Brothers in Arms program, where they're getting EMS providers to be the donation source. where they're using creative recycling programs where as the blood products go towards end of life, they're getting them back to the trauma center so that they can be used in the OR right away, which both cuts down loss of product and also cost. So there are some really, really creative ways to solve this problem. We just have to find them.
Thank
Absolutely.
you. I just wanted to follow up on that idea of the costs and the supply difficulties. So TXA we've talked about before, it's cheap. It's a couple of dollars and it can sit in the back of the ambulance for months and months, I think a couple of years before it expires. But blood, of course, it can't sit for years at room temperature in the ambulance. So can you just briefly talk about kind of costs and supply and expiration issues for EMS agencies who might be thinking about considering using blood products?
Sure, and Josh, please jump in here. I was just going to jump on this because I routinely purchase blood products. So it's about $400 a unit. It's pretty highly regulated, so you would have to have a specialized refrigerator with temperature monitoring and remote control to the refrigerator should you have a power loss or something like that. Those refrigerators are about $30K. You can buy refrigerators for a ambulance, which are on the order of about 15 or 20K. I wouldn't bother because an igloo cooler works really well. And I know where you can pick those up for about 12 bucks. But it does get a little bit tricky about making sure that it's packed appropriately in terms of, using those gel packs and whatnot. The blood products themselves, whole packed red blood cells last 28 days before it needs to be be discarded. What we used, the fresh frozen plasma, thawed plasma, has a very short shelf life, only about 4 days. So that gets really tricky and led to our very high courier costs. But liquid plasma, which is the never thawed version, can last 28 days. That's tricky because blood banks don't have a lot of use for liquid plasma, so they don't keep a lot on hand. But again, that's an opportunity to have a creative discussion with your blood banking folks. So knowing that you could have potentially 28 days of storage in your base refrigerator, and then being able to put it out in an igloo cooler at shift change, starts to make things feasible. And then the other really important part is the recycling piece, where at some pre-designated time, say 24 or 25 days, a courier comes and picks it up and brings it to the trauma center so it can be used and not wasted, as opposed to discarding it at 28, is really critical. But they're challenges, but they're all surmountable, and there are organizations throughout the country, air and ground, who have come up with solutions to these problems. So phone your friends.
Yeah, and obviously, we've recently looked at this from a cost effectiveness perspective, and it turns out to actually really be pretty cost effective as an intervention, benefit versus, what a program like that would cost an agency.
I think all of these are such important considerations, and it really illustrates how it does take a system to save a life. So, it's not just that you roll out this program and one day we have to have the partnerships in place and those relationships to be able to have this system of care. And you all did a great job at displaying the data in a transparent way and including some of that discussion about those logistics that are really important to consider for this type of program and are likely to vary across geographies, right? And now, sadly, I do have to take us to our conclusion, but I know that you are both doing really exciting pre-hospital work, and I do want to give you a chance to let us know about, I saw that the P-Power study is coming. Is there something else that we should be keeping our eye open for in the near future?
I don't know if, we've got a lot of interesting stuff coming through the Lights Network that Frank and I, another DoD funded to look at pre-hospital airway management. We're going to be looking at cold stored platelets, pain management options, and hopefully eventually we'll be looking at freeze-dried plasma as part of that. So a lot of exciting things on the horizon for pre-hospital trauma care.
Yeah, and the other thing I would add to that, Josh, is that we also have a multi-omics platform that our collective boss, Dr. Tim Billiar, has built, and it's really getting down to the point of the personalized medicine thing, trying to identify the patient population that benefits most. And that's always one of these frustrating things. We do these tremendous trials, and I have the fortune of cutting my teeth on a lot of the ROC trials, and they were really well designed and really well implemented, and people worked incredibly hard on them, and many of them had I wouldn't say negative results, they were informative negatives, right? They were where we weren't able to show a difference between two therapies. And a large part of that is that we didn't know who to apply them to. And I think that will also be the future. It's always great to have some whiz bang new piece of technology, and certainly when we do get freeze-dried plasma, that will be a game changer for all of EMS. But being able to know who will benefit from the intervention is going to be something that in the next 10 or 15 years will become increasingly more accessible.
Absolutely. There's definitely some exciting stuff on the horizon for pre-hospital trauma care. And again, I can't thank you both enough for sharing your time with us and this excellent study and all of the transparent data that you have presented today. Thank you for your dedication to high quality EMS research in practical, pragmatic settings. And just can't thank you enough.
Thanks. It was exciting to be
here. And we're also grateful, Remley, for you and for your counterparts as well, not just as educators, but there are not enough EMS centered investigators out there, and we need to make more of them. So hopefully you guys can find some more young people who are interested in pursuing careers in hard science, but still have a love for EMS and pre-hospital care.
Absolutely. And that's what we're hoping to do with this journal club and some other endeavors we have. So thank you for sharing some high quality EMS research and setting the example. All right, Dave, do you have last words before I take us out?
I just want to echo all of the thanks that you've given the authors and the wonderful words of encouragement for future researchers. And again, it's International Women's Day, so congratulations, Remley, and all of the incredible women who are part of EMS and the world. So thanks.
Absolutely. Here's hoping to bring some more people over to the dark side of research. Now it is the time where I have to script us out. So as a reminder, we do have the education version of this podcast will be happening on Friday, March 26th. And we are going to be back here with the clinical version of the podcast next month, second Monday of the month, which will be April 12th, if I'm correct. So thank you all again for listening, and we look forward to nerding out some more next time.